like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Welcome to the National University of Singapore Yong School of Medicine Healthy Longevity webinar. We have, as always, I would say, a great program tonight, talking tonight about stroke and aging. Associate Professor Raymond Seet is our guest tonight. He is a clinician scientist, so really it will be a great presentation about real clinical problems. I would like to remind you to use the Q&A function to set questions or your comments. But also I would remind you, just if you want to hear a speaker we should invite, please give us that hint, but also send us a little bit of information, what kind of topics you would like to hear. Your comments are very welcome. We always start with a short presentation, which we will do today. And today it's Charmaine Tien. She is a PhD student from our Center for Health and Longevity at NUHS. And she will talk about a very relevant topic about neuronal blood markers and its association with mortality in old age. So how to predict mortality. Charmaine, the floor is yours.
Hi, everyone. As mentioned, I'm Charmaine, and the research article I'll be sharing with you today is from the journal titled Nature Aging, and it's titled A Neuronal Blood Marker is Associated with Mortality in Old Age. And this was actually from a group in the University of Tübingen in Germany. So as we grow older, our mental function as well as physical ability decreases, and this often leads to ill health and ultimately death. So because of this, these two measures are also often used as indicators of someone's mortality. So this research group actually looked towards a protein called neurofilament light chain, otherwise known as NFL, as a potential biomarker to actually measure cognitive decline associated with aging. And more importantly, they wanted to know if NFL can be actually used as a good indicator of mortality as well. So essentially, using blood plasma samples they obtained from a cohort of people of different ages, essentially from 21 to 107 years old, they found actually that NFL levels increased as your age increases, and it's actually also linked to changes in neuronal function. So this is actually quite consistent with previous studies that show that NFL is age-associated and also associated with brain activity and function. So next, they went on to look at the survival of centenarians using NFL. So what they did was they took centenarians, which are essentially people above 100 years old, and they collected blood from this population. So after they collected blood, they followed up this cohort from either till the time they died or 4 years after blood collection. So other measurements that they took was looking at their physical abilities as measured by ADL test, and also their cognitive function, which was measured by MMSE test. So what they found very interestingly was NFL levels firstly correlated to the survival of the centenarians. So for instance, centenarians who had very low levels of NFL actually survived the longest, more than 3 years, or were still surviving at the time of measurement. Also, they found that NFL levels were also correlated with disability as well as cognition. So for example, when seniors had high disability and poor cognition, this was also reflected as very high NFL levels. So they also wanted to test if NFL was a good predictor of survival. So taking an area under the curve, what they found was NFL was a more effective predictor of survival as opposed to the traditional tests of MMSE, looking at cognition, or ADLs, looking at physical disability. And they actually came up with a prediction model. So for instance, if they combined NFL measurements with ADL measurements, they could actually robustly come up with a prediction model for how long centenarians were able to live to 103 years old. So just as an example, if you see in table 3, if, for example, your plasma NFL levels were less than 49.4 picomoles per milliliter, and you were moderately disabled, there's actually a 33% chance to reach 103 years old. So this is actually a very unique way and a new way to predict survival in centenarians. So lastly, because they found that NFL could accurately reflect survival, they wanted to see if NFL could also equally reflect aging interventions effects. So for example, dietary restriction is known as something that when you are put on, it actually improves lifespan and also prevents age-associated decline. So they subjected these mice to dietary restriction, and then they measured NFL levels of these mice. So what was interesting was that mice that were put on dietary restriction naturally lived longer, but more importantly, these mice were actually shown to have lower NFL levels, specifically at 16 and 20 months of age. So this actually further supports the fact that NFL is a very unique and suitable biomarker to reflect survival in both humans and in mice. So taken together, this study shows that the decline of the nervous system, as reflected by NFL, does contribute to mortality in the elderly. And more importantly, the study also highlights the fact that NFL may be a very suitable biomarker to predict all-cause mortality, which ultimately can influence medical decisions and medical care in the elderly. So if you're interested to find out more about this paper, do go check out the journal article on Nature Aging. So I hope you enjoyed this little snippet and please enjoy the rest of the webinar. Thank you.
Thank you so much, Shamin. I think it's a great marker, NFL, and we should also test that in our cohorts and add more to them. I think prediction is very important in clinical care. And I think Associate Professor Raymond Seet will also agree with me, but I will introduce him in a second, because I would like to draw your attention to our opening of our Center for Health and Longevity. As you have seen in the introduction slide, and you see it now, we are opening our center on the 7th of September, and that's a very big day for us. We have a hybrid program for you, so it's on Zoom, but also in person, with, I would say, top international researchers, including, to name just a few, Professor Matt Kaberlein, for example. You might know him about, he invented the dog study, testing actually geroprotectors in dogs. But also James Kirkland is coming. Professor Kirkland is very known for applying senolytics in humans, so to remove senescent cells. Professor Nir Barzilai will also be there, and you might know him he is the inventor of the TAME trial, which is testing metformin in older individuals. And that's the first trial being recognized by the FDA to test actually medication in humans. Professor Tom Rando is also there. Professor Rando is known for his stem cell research, and he was the first one actually doing parabiosis, stitching animals together to see what kind of factors are there to influence animal aging, but also then human aging. Felipe Sierra, Dr. Sierra is there. He was the former head of the NIA, the National Institute of Aging in the US, and is now with Evolution. So in many, many more you see on the slides. And it's a hybrid meeting, but I have very good news. There are a couple of seats left available, maybe for you, to not only see these brilliant international speakers online, as you always do during our webinars, but also in persons. For clinicians, there might be a little bit extra even, and that's our panel discussion in the afternoon, where we discuss if Singapore is ready for implementation of longevity at this moment in time. Can we actually implement what we already know, what we hear from all the international stars, and what we ourselves do at the Center for Healthy Longevity? Is that ready for clinical implementation? And I would say, yes, it is. But let's see what the panel says. On the 8th of September, we have a face-to-face community outreach event at the Alexandra Hospital. So really, if you're interested in what kind of biomarkers we are testing, we will showcase it there at the 8th of September. For both events, please share the invites with your network. It's freely available. As always, no registration fees. So this is very unique, I would say, for such an international conference. And please use the registration chat box function. So we have a link in the chat box function to register. You are highly welcome. Okay, that's enough for, of course, the Center for Healthy Longevity, and really now going to why you attended today, and that's to hear Professor Raymond Seet. And he is a senior consultant neurologist, so a clinician scientist at the National University Hospital. And he is also, very importantly, the Deputy Director of the Healthy Longevity Translational Research Programme we are all working in at the National University of Singapore. And Raymond completed his clinical and research fellowships in stroke and neurocritical care at the Mayo Clinic, but also in Rochester. So he visited lots of places to do his work. And he also is a recipient of the Senior Clinician Scientist Award by the National Medical Research Council, which is a great achievement. So Raymond will talk about epidemiology of young-onset stroke and translation and insights. And I cannot hear, and I'm very happy to hear him to talk about stroke prevention and treatment. So his title is When Ischemic Stroke Strikes Younger Brains. So Raymond, the floor is yours. Thank you so much for joining while having so much patient care also, and share your knowledge about your research. Thank you.
Thank you, Andrea, for these very kind words and for your leadership with Brian in this successful series of webinars on healthy longevity. And thank you everyone for joining this webinar at this time of the day, right before dinner. So my topic this evening is ischemic stroke, when ischemic stroke strikes the younger brain. So through this talk, I hope to bring your attention to the burden of stroke amongst the young in Singapore and highlight several unresolved clinical questions surrounding the causes and consequences of stroke among young individuals. So broadly speaking, there are two types of stroke. The first being hemorrhagic stroke in patients with subarachnoid hemorrhage, as well as intracranial hemorrhage, both of which can lead to an acute coma presentation. The second type of stroke is ischemic or thrombotic stroke that is explained by sudden blockage of blood vessels leading to interruption of blood flow, potentially causing death to brain tissues and permanent disabilities. Now, this talk today focuses on ischemic stroke, the more common type of stroke, which constitutes approximately 80 to 85% of all strokes seen in Singapore and around the world. Now, 30 minutes is a short time, and I will use this time to cover the epidemiology of stroke and highlight the burden of young onset stroke in Singapore, which could have implications to other Asian societies. I will elaborate clinical challenges when managing patients with young onset stroke, from the uncertainties surrounding the occurrence of stroke in a young individual to the propensity of the young brain to swell and cause malignant cerebral edema. And the final part is one that is more obvious, whereby younger patients tend to live longer and harbor greater odds of developing another stroke and cardiovascular disease in their lifetime. Now, the study of stroke is an emerging field. I will end off this talk by highlighting ongoing research to better understand stroke mechanisms and potential tools and ways to lower stroke-related complications. This slide describes the latest trend and epidemiology of stroke in Singapore based on data released by the Singapore Stroke Registry in 2021. Now, the graph here compares the number of new cases of stroke between 2006 to 2019, showing a steady rise in numbers, peaking at 209 new cases per 100,000 individuals in 2019. Adjusting for age gives us a relatively flattish line across the years, highlighting the contribution of our aging population in driving the higher stroke numbers here in Singapore. Other than airports and cuisine, Singapore is also leading the pack when it comes to stroke. We have one of the highest number of new case strokes and number of stroke survivors in the developed world, anchored by our unprecedented rise in life expectancy. This is the distribution of the number of new cases of stroke, where the highest number of new cases occurred in the 60 to 69 years age bracket, followed by the later 2 decades. The age of stroke in Singapore is 69 years, which is approximately 2 to 5 years earlier compared with registry data from Japan and the United States. By contrast, the median age of death of stroke patients is 79 years. This means most stroke patients live for a median duration of about 10 years after the onset of stroke. Now, although the risk of stroke is largely driven by age, 25% of stroke involve individuals below the age of 60 years, a period when many are likely to be economically productive, have a relatively younger family to support, and living in Singapore, certainly mortgages to clear. And this slide reminds us that stroke is largely a silent yet impactful disease. When a typical small culprit clot that measures between 2 to 6 millimeters occurs, this could trigger small ripples, as what you see here, before leading to a tsunami of disruptions that takes place to lives and livelihoods, unfortunately, often without the knowledge of the greater community. Most strokes would lead to motor and physical impairments that contribute to weakness, fatigue, speech, and swallowing difficulties. And stroke can trigger a roller coaster of emotions leading to depression and cognitive impairment. The financial impact of stroke arises from a high cost of prolonged hospitalization and rehabilitation, as well as the loss of employment and income. Social impact of stroke is especially greatest to societies with small families, such as those in Singapore, as it is not uncommon for families to take time off work to also serve as primary caregiver to the patient. As stroke treatment rapidly evolves, so do healthcare policies to deliver and also finance the increasing medical needs of a stroke patient. Pathogenesis or mechanism of stroke involves a very complex interplay of different immune subsets, cell players, glial tissue, and breakdown of the blood-brain barrier. Therefore, knowing the origins of stroke, where these clots come from, and the circumstances leading to their release is important, as these could guide doctors on how to prevent another stroke and help design a personalized treatment strategy to reduce the risk of a recurrence. Despite extensive investigations, the mechanism of stroke remains unknown in up to 50% of patients below the age of 55 years. And it is possible that some of these risk factors remain unknown and may be elusive to existing tests. When risk factors are uncovered, they are often mild and not at the supranormal levels that you would expect to see for someone who presents with an end organ damage, such as a stroke. Now, this slide lists textbook information on some of the modifiable and non-modifiable risk factors of stroke that center around lifestyle, pharmacological, and surgical treatment. The relatively heavy burden of young-onset stroke in Singapore invites us to relook and rethink several of these risk factors and how the absence of these traditional risk factors in many of our patients could highlight the need for further research into young-onset stroke. In line with this talk, for example, could a study into the biology of aging provide us with some useful insights to this clinical problem? Now, the figure here highlights the relationship between chronological age, as you see on the x-axis, and biological age on the y-axis, where among individuals with normal aging, the relationship should be a hypothetical linear straight line, with a certain degree of variation to account for human diversity and gender. Therefore, if a readout points to the upper half of the figure, this would imply an individual who is biologically older than their actual age, what we suspect for patients with young-onset stroke, whereas a data point in the lower half of the figure would support biological youth, individuals who are biologically younger than their actual age. Organs start aging at different times, and some diseases are known to accelerate aging of the different organs at different age. So therefore, biological aging is therefore central to clinical researchers and trialists keen to examine the biological aging in humans to allow them to devise interventions aimed at slowing or regressing the biology of aging. This is one of our works where we profile a wide range of blood-based biomarkers amongst healthy individuals and explored the use of advanced statistical and AI modeling methods to refine selection and weightage of the different markers in predicting biological age. This is obviously work in progress that brings the conceptual graph into some form of reality as we work to stress the various models with various diseases, including those with young-onset stroke. Through these studies, we hope to one day able to categorize and biologically fingerprint individuals according to their vascular age and classify them into groups of early premature aging, average aging, and also the supernova or supernovascular aging that implies biological youth. At the same time, wearable technology and devices has seen a tremendous growth in interest and requires very little introduction, especially in Singapore. Here, almost everyone owns a wearable device, and about half of the population would own 2 or more wearable devices, either for contact tracing at the peak of COVID-19 or to track basic health parameters. And as the benchmark for chipset quality and sensor accuracy increases substantially over the past decade, many of us are now relying on wearable devices to provide us with pointers on indicators of health and disease. So this is an image of a smartwatch capable of collecting a host of digital signals that could hypothetically also provide us a better resolution of our ability to determine the vascular age of a person. So previously, we used blood-based markers to provide an estimate of biological aging in terms of years. So could these wearable devices also allow us to refine our estimates of biological age to get further into with greater resolution, one that allows us to refine it into months, weeks, and perhaps days. The potential of wearable technology seems limitless these days. This important publication by Dunn and colleagues, published in Nature Medicine, highlights how signals from commercially available existing wearable devices can now reliably predict blood information and accurately predict hematological and metabolic parameters that typically require painful venipuncture and costly investigations. All of these efforts could inch us closer to the holy grail of aging to allow us to identify patients who may harbor signatures of accelerated biological aging and implement personalized measures to avoid stroke and its catastrophic. At Accelerated aging could explain stroke mechanisms, and the reasons why some people develop stroke at a young age remain uncertain and unclear at this moment, a subject that requires further investigations and serious funding. So as discussed earlier, patients with young onset stroke harbor a significantly higher risk of developing another stroke or cardiovascular event in their lifetime. So to address the questions why some individuals are more prone to developing another cardiovascular event, we have also made important inroads to molecularly identify and track blood signatures of stroke patients who subsequently develop another stroke and cardiovascular event. So these signatures, as what you see here, have been validated in vivo and animal models of stroke and independently verified in a separate stroke cohort. So findings such as this are important as they open up the possibility of us to objectively quantify the risk of a person developing another vascular event based on objective prognostic markers, and hopefully introduce some form of personalized medicine to the cohort of individuals at high risk of developing a recurrence. So some members of the audience may be aware of this remarkable progress made in acute stroke treatment that has led to recovery and improvement and return of patients to their families and also to their communities. Patients who were previously resigned to the unforgiving biology of cerebral ischemia. So these are actual images of images for a 45-year-old lawyer who presented approximately 50 minutes after developing an acute onset weakness involving his right upper and lower limbs during a client meeting. So his arrival at the emergency room prompted a series of multimodal imaging investigations, such as a CT scan, a CT angiogram, a CT perfusion scans that allowed us to quickly locate the blood clot and assess the extent of brain damage. This is important for us to evaluate the amount of salvageable brain tissues and also to coordinate the optimal. So in this case, following a highly coordinated evaluation, the series of fibrinolytic TPA treatment and also endovascular treatment culminated in the extraction of a blood clot as seen in the image here. So these are more examples of blood clots retrieved from stroke patients, highlighting, if you see here, their heterogeneity in terms of size, color, as well as composition. So analysis of these clots can potentially provide us with useful insights into the origins of stroke and circumstances leading to their dislodgement into blood vessels within the brain. Now, using electron microscopy methods, this slide here shows magnification at 100 times to 500,000 times, as well as 3,000 times, showing the relationship and also orientation between red and white cells and platelets. And also, if you can appreciate the wet-like fibrin strands that hold these blood products strongly together. More examples of the clots. We had a field day when we had the opportunity to image these clots. More examples of blood clots retrieved from stroke patients, showing in this case activated platelets, inactivated platelets, and also the orientation between white blood cells, red blood cells, fibrin products, and also the distribution of clots in relation to the other key players in thrombosis. So subject to funding, of course, it will be interesting to compare and contrast blood clots of patients with young onset stroke and those of older patients to assess drivers of stroke mechanisms in patients with different extremes of demographic profiles. Ischemia to brain tissues can lead to a loss of integrity of the cerebral microvasculature, causing degradation of the laminar basal lamina, and of course, breakdown of the blood-brain barrier that previously separated the brain from the blood circulation. An undesirable consequence of breakdown of this barrier here is seepage of blood into brain tissues following a stroke, a process that is aggravated by the use of fibrinolytic agents intended to dissolve clots such as alteplase and damage from the use of devices during endovascular treatment. Using symptomatic intracranial hemorrhage as what the image here suggests. Affects approximately 2 to 7% of patients following acute reperfusion treatment, which could trigger massive brain swelling as seen in figures A and B here, potentially damaging surrounding normal brain tissues. This is the area of infarction, and these are normal brain tissues that appear to be under stress through the midline shift, as what you see here. And also increasing pressure onto the neighboring structures, especially to the brainstem, which controls vital functions such as breathing. So to relieve pressure, removal of a segment of the skull is warranted, a process known as hemicranectomy. This is an intraoperative image of the brain after removal of the skull, showing a swollen brain and engorged blood vessels. So, ladies and gentlemen, this is the image of a lipid-rich brain that shows ridge-like elevation known as gyrus and areas of depression and indentation here known as sulcus. In one of our early works, we systematically collected blood and extracted plasma from patients with hyperacute stroke and observed the temporal release of several lipid-based oxidative biomarkers into the circulation. With this work, we were amongst the first to show that it is feasible and possible to use blood as a tool to examine the downstream consequences of stroke and as a tool to provide us with a window into the complex biochemical activities that occurs following ischemia. A breakdown of the blood-brain barrier could also be a good thing, as it could trigger the release of a range of RNA, microRNA, and also protein markers into the circulation. So the heat map here demonstrates upregulation of several microRNAs during the hyperacute stages of stroke compared to healthy controls. So this is one attempt to leverage on this new information and also to explore the use of microRNAs to differentiate patients, potentially allowing us to stratify individuals according to their bleeding risk by assessing the extent of breakdown in the blood-brain barrier. Further works can yield a personalized approach to treat stroke patients according to their biological predispositions. Following ischemia, neutrophils are also some of the early and first responders to the site of injury. So although neutrophils are effective to limit and mop up damaged brain tissues, excessive migration of neutrophils to the site of injury can paradoxically aggravate injury and induce cerebral edema. So for these reasons, we were attracted to the study of leukotriene B4, which in vivo is a potent chemoattractant for neutrophils. It attracts neutrophils to the site of injury. So here we showed good correlation between leukotriene B4 and also neutrophil count, and profiled its temporal release and showed how this could have important prognostic implications to stroke outcomes, where excessive levels of plasma LTB4 here is correlated with poorer outcome, showing that excessive level could lead to more harm than good in some patients. And also using different antagonists, we showed that lowering in leukotriene B4 could result in reduction in stroke volume and also brain swelling, a finding that could have clinical implications to the management of malignant edema in young-onset stroke patients. So to summarize, I hope to have brought to your attention the clinical epidemiology of young-onset stroke patients in Singapore and highlight questions surrounding uncertainties in their stroke mechanisms, and also increase lifetime risk of developing another cardiovascular catastrophe, highlighting and in the process highlighting ongoing molecular, wearable, and AI works to address these gaps. With many pitch, if I may, I would like to pitch for the audience to consider submitting your best works to the Annals of the Academy of Medicine that, amongst others, has a strong focus on aging. Annals currently carries an impact factor of 8.7 and is the leading Asian medical journal in its category. So with that, thank you, Andrea, for your time, and also we'll be very glad to learn and also take questions.
Thank you so much, Raymond. A very great presentation and a great journal. I think you are affiliated with that journal, isn't it? You're an editor there.
Yes, I'm presently the editor.
Yeah, look.
No conflict.
No. It's fine to pitch here. It's fine, really fine to pitch. But let me start with asking you the first question, and that might be a little bit controversial. Is stroke a lifestyle disease?
Yeah, so I mean, with the cuisine and also access to all the different food, the best flavors of Asia and also Europe, there is always this thought that stroke is a lifestyle disease, one that is attributed to traditional risk factors such as hypertension, hyperlipidemia, as well as cigarette smoking, etc. But if you think about it, in Singapore compared to elsewhere, the prevalence and also the number of people, proportion of individuals smoking is not as high as what you expect elsewhere. And if you were to scrutinize the risk factors of stroke patients at the time of stroke, many of them do not have such overt, poorly controlled risk factors that you expect for someone with an organ damage. But instead, a lot of these risk factors are mostly mild risk factors. So although it is definitely possible that there is always that overlap of risk factors and also diet, physical inactivity coming to play, contributing to the risk of stroke, the data that we have reviewed suggests that there may be something more. And I think the data that we have examined suggests that there could be some biological predispositions. But I think for clinicians, a lot of us are very interested, not so much for those non-modifiable risk factors like genetics, but we are looking for pathways and also ways to intervene those factors that are modifiable. And I think the shorter answer to your question is, I think there is much, we still do not know much. I think this is something that we ought to focus and also emphasize resources to answer some of these basic key questions. And the other point is that in other countries, developing countries where the incidence of rheumatic heart disease and also drug use is high, which may account for the higher risk of stroke in those populations, we do not see as much those as much here, but yet the proportion of individuals with stroke still is comparable, if not exceeding those in those countries.
Yeah. So if I understood correctly, and you compared epidemiological data of Singapore with these of Japan, for example, that the incidence of the first stroke is much earlier in Singapore at the age of 69 years and much later in Japan. And it's not only lifestyle. So what kind of other factors would there be? And I'm already thinking about a study design where you have the same ethnicities, if it would be genetic, but individuals living in a different environment, such as in Singapore, where we have this multicultural inhabitants. So how does that fit, looking at other Asian countries and Singapore in the incidence of stroke, which is much earlier?
Yeah, so the pattern of stroke, so Japan is always a unique anomaly whenever you consider the epidemiology of stroke, because Japan is differences in their ethnicities and also differences in their diet, and also the fact that a lot of these the lifestyle practices are very different compared to other countries outside of Japan. So a better comparison would be in China. So in China, in China, stroke is the leading cause of death. In Singapore, it's number 4. In China, number 1. In India, it's still number 1 or number 2. In other Asian countries, such as Vietnam, it's still the leading cause of death in that population. And if you were to scrutinize and also examine the age of stroke onset, we are seeing quite comparable age. And in those societies, some of them may be a lot earlier compared to in Singapore. I think that the previous understanding was limited access to healthcare and also limited access to screening of risk factors in those population. But as you know, here in Singapore, we do have one of the better healthcare screening systems and also better access to healthcare, and yet we are still observing incredibly high rate of stroke here in Singapore.
So something to solve that mystery. Another mystery is that Singaporeans' lifespan is so high, and which is even now higher than that of Japan. So actually, we are doing better in Singapore. But anyway, let me move to an earlier step. Are there any prediction models to predict the first stroke? So you also try to analyze it a little bit to predict the second stroke, but do we have anything in hand next to the conventional lifestyle factors in the cardiovascular disease risk scoring systems to predict a stroke in already younger individuals?
Yeah, so this is an ongoing effort and ongoing study to examine risk factors for stroke. We tried to use the simple way to look at traditional risk factors. We failed rather miserably because we were not able to pinpoint risk factors. And I think the interrogation of risk factors would ultimately bring us to what we are slowly progressing into, the search for new genetic markers, the search for existing proteins, and also to be able to identify candidate pathways that ultimately allow us to have tools, for example, as what we showed, tools to measure a person's biological age, for example. It may not be the final tool, but ultimately, hopefully, it will allow us to congregate towards a method of estimating the biological age or the vascular age of an individual. I think that's those are the things that are efforts that are ongoing, and all this subject to serious funding, as I highlighted earlier, because it's not easy to fund stroke. Often it is considered an overlap often area between cardiovascular research as well as neurological research, where one would consider stroke to be a cardiovascular disease. So therefore, the neurological pods will not fund them. And likewise, the other would consider stroke to be a neurological disease. The cardiovascular side will not fund them. So I think these are some issues that are in existence, serious funding that need to really bridge these differences and also allow us to get to the bottom of the.
So if somebody is here in the audience of a funding agency, so let's fund them out of both pots, so the cardiovascular and the neurology one. So hopefully that will help. But tell me, so it's such a high proportion of individuals having strokes already at quite younger ages. Are the pathophysiological mechanisms, and there was maybe also the prediction tools different, you think? You don't know maybe yet, but you think in earlier and later age?
At this point in time, we are screening individuals using traditional risk factors and trying to get them to do a very good work in physical activity, modifying, treating high-risk patients with the appropriate anticoagulants and also antiplatelet treatment for patients with high risk of developing atrial fibrillation-related stroke. But if you were to look back and take a step back, the yield of the proportion of individuals with atrial fibrillation in this age group below the age of 60 is low. Okay, and mood scores, for example, the CHEST-VAS score, we will only assign a score of 1 if you exceed the age of 60 based on the cutoff determined using the Caucasian population. So as a result, even for patients who are screened positive for atrial fibrillation, they may not necessarily be converted to anticoagulant. So I think these are some of the ongoing mysteries that we will need to solve because I think when screening individuals with just traditional risk factors, we have not been very successful. And I think that is an impetus for the research community to address, because these are also individuals who are, as what I highlighted earlier, economically productive, who have a young family, and who where stroke impacts them more than just as a physical handicap, but more at the family and also at the society level.
Absolutely, absolutely. Before going to Stephen Rush, who has lots, I think, questions from the audience, I have one more question for you, if I may, and it's a little bit a personal question. What is your driver dedicating so much of your time and maybe even personal time to this very important topic, stroke, even in younger individuals? What drives you?
Complexity, and also yeah, I mean that is a question that we can take later another evening, because that will take more than 30 minutes.
Okay. Good. But thank you so much for doing such great clinical work at NUHS and doing so much research and being such a brilliant clinician scientist. Over to Stephen. Stephen, what are the questions of our audience?
Yeah. First of all, thanks, Prof Seet, for your wonderful presentation. I learned a lot about stroke, and I didn't really know it's kind of happening in the younger population as well. So that was something new for me. So we have quite a number of questions. I'll just select a few of them. So one question is, what are some of the major reasons behind a younger Singapore population now experiencing a higher incidence of getting a stroke? So you didn't see it in the past, we are seeing it now. And another aspect to that, is there a gender difference with regards to the incidence of stroke in a younger Singapore population?
The younger age group below the age of 60, there is a higher propensity for men to develop stroke, and I think this is also seen in other populations. But although females are the incidence is lower in females, there are very good data to suggest the outcomes for females are a lot poorer compared to men. Okay, I think there are different attempts at explaining this observation, and I think the key acceptable explanation is that the biology of stroke could differ between these two groups. One could be due to that may be related to, so it can be related to the different ways how an individual seek treatment, and also how an individual present with symptoms. And I think this is something that is widely known and also accepted. As we discussed earlier, there are still a lot of uncertainties as to the reason why a person develops stroke at such a young age. Often the risk factors are not as severe as what you expect for a person with any organ damage. And a lot of these patients will present with HbA1c, even for diabetes, right? Because Singapore is the capital of diabetes in the world. So even for diabetes, the A1c levels are typically between like maybe about 8 to 9, and they are not commonly in the crisis level of between like more than 10, for example. And even for blood pressure, they may have high blood pressure, but often this is not associated with left ventricular hypertrophy, as what you see on ECG. So suggesting that a lot of these risk factors are at the mild stage, they're not at the super advanced that you expect for a person with an organ damage. And I think we also routinely, rather religiously, screen these individuals with all the prothrombotic blood tests to assess a person's inherent tendency to develop spontaneous blood clots, but have not been very successful in identifying a lot of patients. Perhaps the yield is less than 1 in maybe 10,000 people that you screen. So the incidence of such polymorphisms, because I see one of the questions here is factor V Leiden mutations, is almost is very extremely low. So this is not some of these risk factors that have been associated with prothrombotic young onset stroke is not something that we encounter here.
I think another question is regarding biomarkers of stroke. So there's one question about whether anyone has looked at extracellular vesicles from the patient plasma for potential biomarker identification. So would these be known biomarkers for young onset stroke?
Yeah, so this is an ongoing question that we are also interrogating from our end. So by extracting exosomes, microvesicles, we are also looking at the protein expression within these cellular components, and also with a view of trying to extract protein expressions or RNA, for example, that's present in a more pure form, and allow us to perhaps remove noise whenever we bring for analysis. This point in time, I think that is, I'd like to remind the audience that stroke is a clinical diagnosis. So, there are different purposes and uses for stroke biomarkers. A set of biomarkers that essentially that's used to diagnose stroke may not gain a lot of traction for clinicians, because ultimately clinicians will rely on imaging modalities and clinical definitions before instituting stroke treatment. So therefore, a lot of efforts are being geared towards looking at biomarkers for stroke prognosis, for example, and also using more pathway analysis to at high value pathways. And I think our group, as well as several others, are presently pursuing some of these leads.
I think there's another question on risk factors. So is insulin resistance, just now you mentioned, talk about obesity in Singapore. So is insulin resistance a major risk factor? And if so, what would be the recommendations to mitigate or reverse this?
The ultimate consequence of insulin resistance is metabolic conditions such as diabetes. We previously profiled our whole of the in NUH and observe a prevalence of 40% diabetes 30 to 40% diabetes in the whole cohort of stroke patients. And I think this is also replicated in countries such as Malaysia, and also to a lower extent in China. And I think this is an ongoing because at least the outcome for diabetes stroke patients in Singapore depends very much on two factors. One is the level of body mass index, and also the whether the diagnosis of diabetes is new or old. Okay. It's this entity that we stumble upon called the lean diabetics, meaning that diabetics who individuals who develop stroke despite harboring a normal BMI, and as compared to another more insulin resistant population of diabetic with a higher BMI of maybe 28 to 32. And we observe that increasingly those with lower BMI are the ones who go on to develop. I think this is something that worthwhile pursuing to explore the potential mechanisms. Unfortunately, in that particular study, we didn't separate individuals according to the age of stroke onset. So I think that's another question that we could potentially look at.
Okay, thank you. So maybe now we move on to just one or two quick questions on stroke prediction and stroke diagnosis. So someone asked, how accurate are the wearables in predicting stroke? So are there any statistics done so far for this?
At this point in time, I think the most famous information for wearables would be the detection of atrial fibrillation using your standard Apple Watch. And I think a lot of companies have also evolved their chipsets so as to allow us to define such new novel risk factors. As I mentioned earlier, the detection and yield of atrial fibrillation in the young population, especially those below the age of 60, in a population where the incidence of rheumatic heart disease is low, okay, the yield is not as high as what you expect in maybe other countries. So I think this is also probably quite reflective, and it's also mirrored in other more developed countries with more developed healthcare systems. And I think the wearable space is a very high and rewarding space. There are a lot of information that are being extracted on a daily basis. I think there's a lot of interest in looking at not the processed data, but the unprocessed raw data, because within that, it's also this thought that that a lot of new information may reside in the raw data. And I think this is subject to a lot of, this is something that a lot of our clever AI and also machine learning colleagues to help resolve and also come to a
okay, maybe we'll have just one last question. So in a clinical health screening setting, so is there like, if you can say one test, which is the kind of the most accurate to predict the chance of stroke? And, you know, this would be kind of a more generalized screen, maybe from some blood biomarker. So a slight follow-up to that is, how far are we away from personalized stroke diagnosis and treatment?
Okay, so the most important risk factor here is two risk factors: high blood pressure, diabetes, and also high cholesterol. How far are we from getting a personalized risk factor? I think we are probably closer now compared to where we were before COVID, because a lot there is a greater acceptance of wearable devices, at least in the last 2 to 3 years. And could there be a molecular marker that may emerge in the next few years? I hope so. I think there are a lot of nice tools that are already available that allow us to do point of care tests, and I hope my colleagues in the bioengineering space and also the innovation space will be able to continue their good work and also help us use some of these platforms to narrow down the patients who may be at higher risk of developing a stroke.
Thank you, Prof. Seet.
Thank you so much, Stephen, for handling all these questions and moderating them. And thank you so much, Associate Professor Raymond Seet, to be our guest today. I at least learned so much, that not only that we have to fund more stroke research, but that there is absolutely a distinction between the young and the old onset of stroke. And these beautiful images of actually the platelets and the erythrocytes, etc. It's fantastic work you're doing. Thank you so much.
Thank you, Andrea, and also Stephen, for organizing this.
Yeah, thank you. A reminder for you, the audience, yes, again, please register for our longevity conference on the 7th of September. It's hybrid, and you might be the lucky one to catch one of the last seats we actually have in the auditorium to meet the most brilliant, I would say, minds in our field in person. Or, as always, you can join us by Zoom. That's what we learned during the pandemic, to do it hybrid. And so you will learn about the doc study of Matt Cabeline's analytics of James Kirkland, taking metformin, yes or no, being expressed by Nia Barzilai, and biological clocks, for example, by Eva Bishop, but also other speakers. And join us on the 8th of September, where in the Alexandra Hospital, we open up our doors that you can actually see how we do the research. You can find the registration link in the chat, but also in the chat, please leave us messages who you would like to hear from what kind of speakers, etc. The next episode is on the 1st of September 2022. So in 2 weeks' time, the next speaker is Enio Kusker, who is from Longevice. And he will talk about the preventative health and how we can already prevent age-related diseases at a much, much younger age. And the next host is my dear colleague, Professor Brian Kennedy. Take care.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.